Welcome, everyone. Thank you so much for joining. So we're excited to talk to you here today on our webinar, which is part of the webinar series, Patient-Centered Value Assessment and Alternatives to the QALY. This is a four-part webinar series, and this is the third installment. So today we'll be talking about health years in total as an alternative to the QALY. And first, I'll just talk a little bit about the NHC. I know that we have some non-members in the audience, so thank you so much for joining. The National Health Council is made up of more than 180 national health-related organizations and businesses, and our core membership includes the nation's leading patient organizations and other health-related associations, nonprofits that include the provider, research, family caregiver communities, and businesses representing biopharmaceutical, device, diagnostic, generic drug, and payer organizations. So you can see we have quite a broad range in our membership, but as always, representing the voice of the patient and representing patients with chronic diseases and disabilities. You can see here the breadth of our patient organization membership. So I hope many of you are on the call today. Always great to have our members here. But if you are interested in membership, you can always reach out to our membership department and they'd love to talk to you. Great. So for the agenda today, of course, we'll provide a little introduction. We'll talk about our new updates to the NHC's value classroom, and then we'll get into this alternative to the QALY health years in total. And then we'll have some time for Q&A. So please come with your questions ready. Last time we had a really robust conversation, so I hope that you all brought your thinking caps today. Just as a note, please keep yourself on mute during the webinar. And this is a forum for discussion, so we may be touching on concepts and issues that have different views among stakeholders, so please remain kind to each other. And just as a note, also, we are excited to host this webinar for educational purposes, but the NHC does not specifically endorse any of these specific alternatives to the QALY. And during the Q&A at the end, please submit your comments through the chat or the Q&A function, and please feel free to add comments throughout the webinar. If there's anything that you don't understand, please feel free to ask. So now on to some exciting updates. So in 2016, the NHC launched its value classroom with a grant from the Patient-Centered Outcomes Research Institute within the Eugene Washington Awards program. The classroom's intent was to assist patient organizations get ready for value assessment. And so we know a lot has changed in the field. So then in 2023 and 2024, the NHC received funding to revamp its classroom and launch new tools, webinars, infographics on patient-centered value assessment. So our amazing value work group, which is made up of NHC member patient organizations, provided comments, publications, and updates to this work so we can really focus on bringing the patient voice into value. We will be launching this updated classroom in October, so stay tuned. I know everyone's really excited to see the new products, and we'll also be having some information on the IRA there. So I know that's also something of great interest to you all. We would also like to acknowledge our sponsors for this work, Genentech, Merck, and Sanofi. So thank you so much. And if you're on the call, great to see you. So as I noted, this is the third webinar in the series. We have one remaining, and that will be alternatives to the QALY equal value life years. And so that'll be on October 2nd from 1 o'clock to 1:45 p.m. Eastern, and we'll be joined by Dr. Daniel Ohlendorf, who many of you may know. So we're really excited to have the fourth installment on October 2nd. We will put these webinars on the website, and they will be part of our new value classroom. So just to get everybody moving this afternoon, we have a little poll just to see where you all are coming from. It should be popping up on the right side of your screen, or you can join using the QR code. So I'll give everyone a couple of minutes. We have a lot of research nonprofits, patient organizations, some biopharmaceutical folks. That's great. Great. Well, I'll move on to the next slide. Thank you so much for voting. We really appreciate you being on the webinar today, and we hope that you're able to learn a lot. So it is my pleasure to introduce Dr. Anirban Basu. He is a professor of health economics and the Sturgis Family Endowed Director of the Choice Institute at the University of Washington, Seattle, with joint appointments in the Departments of Health Systems and Population Health and Economics. He is a research associate at the U.S. National Bureau of Economic Research and an elected fellow at the American Statistical Association. His work sits at the intersection of microeconomics, statistics, and health policy. His research also focuses on understanding the economic value of healthcare, generating causal evidence, and lately on the potential for discrimination with machine learning and artificial intelligence algorithms. I know that all of those things are of great interest, so really excited to turn it over to you, Dr. Basu. Thank you so much for joining us today.
Well, thank you, Sarka, for giving me this opportunity. Let me share my screen. All right. Can you all see my screen?
Yeah. Looks good.
Okay. All right. So thank you for this opportunity to present. We develop these health metrics for valuations from different perspectives, and often do not get an opportunity to actually present and explain some of the things to patients and patient organizations. I've been a part of many evaluations where I was a part of the focus group and understanding the patient's needs and what aspects of health they care most about. And thinking through that lens and developing a metric is always hard because there is so much heterogeneity. But what I'm going to present today hopefully would have some semblance of how we think about health from a population health perspective. So just some disclosures to begin with. As I said, in most of the qualitative interviews and focus groups that I have participated in, and most recently, I finished the evaluation for sickle cell gene therapy for National Institute of Health. The two things that always come up that patients say that, what they value and they expect from healthcare is really the recovery and cure, basically the ability to age or survival naturally. And then quality of life, which is a very broad umbrella that includes like functional improvement, emotional, mental health, symptom relief, and everything that's related to symptomatic aspects of undergoing or living with a certain disease or condition. Now, when patients make decisions about their own treatments, or we are talking about individual decision making, different patients give weights to different aspects of these attributes. Some people may actually care more about symptom relief than others, and so on and so forth. But when we are thinking about a population level decision making, for example, on average, what the coverage should be, how should we define pricing for a population of patients, or even resource allocation decisions for research, which type of research we should be doing. We need to generate a common measure of health so that it could be comparable across diseases and across population. And the challenge of developing a common measure of health includes two aspects. One is obviously measuring these two dimensions. Survival is more straightforward to measure because you observe the longevity of people or patients. Quality of life, there has been a lot of work done in the last 30 years to try to measure quality of life, although there are still some controversy that exists. And I'm not going to go in much detail about measuring quality of life, but we can certainly have a discussion later on. But the second challenging aspect is how do we combine these two attributes together to form a common measure of health? And the need for common measure, again, as I said, comes from the fact that we have to make decisions that that affect not only one type of patient population, but variety of patient population across the board. And the most common measure of health that's been used worldwide is the quality adjusted life here. And what the QALYs do is basically they take that quality of life and then take the longevity and just they multiply together, each of them together. Right? And there's a reason for multiplication is because, on average, most patients like higher longevity at higher quality of life and vice versa. So there is a natural interaction between those two, and that's why kind of the multiplicative model had become very popular. Now, obviously, this multiplicative model, this common measure of health, when used for population level decision making, is only a necessary component of decision making, not a sufficient one, because whenever a decision is being made, context matters. So around the world, whenever these kind of metrics are being used for decision making, it's not blindly using these QALYs, but there is a lot of deliberative processes that are involved that many often involve patients and understand the nuances, the severity of the population and everything to build on the quality of life, to give certain weights, equity weights, or certain other considerations to kind of make their final decision. So this is not a mathematical kind of black and white decision based on what the QALY says, but the QALY is a starting point, and there is a whole process around that leads to the final decision. Now, in the US, obviously, as many of you know, both the Affordable Care Act and the Inflation Reduction Act has kind of technically banned the use of QALYs. And that ban for CMS decisions and other kind of coverage decisions in the public sphere. And that ban is driven by this sentence where it, we cannot use something that treats extending life, elderly, disabled, terminally ill of lower value than the extending life of the individual who is younger, non-disabled, and non-terminally ill. And this property, in terms of QALY, comes from the multiplicative nature. It doesn't come from how we are measuring quality of life or how we are measuring survival. It's how we are joining those two attributes together. And in this case, we are multiplying those two together. And that's why this property comes about for QALYs. A classic example is let me just hide this. Yeah. So classic example is that, so on the top panel, let's compare two population, A and B, two different completely diseased population, right? And suppose they have, each of those patients in those population have two options, no treatment versus treatment. Now, under no treatment, in both the population, patients live for 1 year, and this is a completely stylized example. But in population A, their quality of life is only 0.4. Whereas in population B, their baseline quality of life is 0.7. So they are doing a slightly better than in population A. Now a treatment comes along, and the treatment increases the life expectancy from 1 year to 2 years for each of those populations, and increases quality of life by 0.2 units in each of those populations. In population A, it goes from 0.4 to 0.6. And in population B, it goes from 0.7 to 0.9. Now, as you can see, the treatment in both those populations kind of is producing the exact same increment in terms of health, 1 year extension and 0.2 units of quality of life. But when we are multiplying those two, the QALYs would say that the value of health or the health produced by the treatment in population B is slightly higher than that of population. And that kind of comes back to the fact that at the baseline, population B had a higher quality of life. And this is the fundamental reason why IRA and other laws have spoken against the use of QALYs. Now, in typical health technology assessment board, the deliberative process tries to take care of it. But there is this inherent bias in QALYs where you are valuing the same increase in health in the two population differentiate. Now, let's also consider another example, which is the lower panel. And in this case, again, we have two population. Under no treatment, patients live for 1 year, but their quality of life is the same, 0.4 in both the population. But here, when you get treatment, it increases the life expectancy by 1 year, but also in the second year, it improves quality of life than what it was. And it turns out that the treatment actually improves quality of life more in the second year in the population B. So the quality of life in population B with treatment in the second year is 0.8 versus 0.7. Right? In this case, obviously, if you apply QALY, QALY kind of appropriately points out that the value of the treatment in population B is higher than that of population A because treatment here in population B not only increases 1 year of life, but increases quality of life more in the second year than in population A, right? So that's what it does. Now, a very popular metric, which has been around for a long time, but was never used in any other kind of HTA bodies around the world, is called the equal value of life. A different version is the equal value of life gain that Dan Ollendorf is going to describe later on the next talk. But what the EVL does is that because of this problem of QALY, it says when there is a life extension during that second year in this stylized example, let's just not deal with QALYs at all or quality of life. Let's just give 1 to everybody during that extension of life. And if I do so, then the QALY problem goes away, right? So in this case, in the EVL, if I do the EVL, I will get the same value in the first panel. Which is appropriate because the gains were the exact same. But by doing so, EVL misses the value that's generated through quality of life in the second year in population B. So in this case, EVL would give you the same value also in the second case on the bottom panel, where we know that we should be valuing treatment in population B more because it produces more. But EVL kind of misses that part. So the health years in total concept was kind of developed to deal with both these biases, both the QALY bias and the EVL bias. And one of the primary reasons we wanted to develop health years in total is not only to address these bias, but also to convey a simplicity of explaining what we value and how we should view health so that it can be communicated in the policy world. The QALY part, I mean, obviously it has existed for 20 years, but people still have problem dealing with, the multiplicative nature of quality of life and length of life. So what is health years in total? So it's a principled approach used to represent a perceived measure of health, which likely was used in patient in decision making. And specifically, it relies on a large psychological and behavioral economics literature, which says that patients, when they make decisions, or not patients, or any individual, when they make decisions, they often form expectations, they form references. And whatever they experience is valued based on what their expectations are, right? So I'm a ardent Chicago Bears fan, and you can feel sorry for me, but that's fine. But when I expect Chicago Bears to lose and they lose, I'm not as sad. But when I expect them to win and they lose, I'm more sad. So I think my expectation of the reference that I form really determines how I value the outcome of what happens in practice. And so in this case, in terms of health years in total, we form 2 references. One is the best quality of life possible, and the other one is the best life expectancy achievable. Doesn't mean by what treatment. Across all your options, what is the best life expectancy possible? And once we form those references, then the outcome of any one treatment is kind of valued not only the outcome that I experience or I would experience, but what it means in terms of my reference point that I have set in life. So in this case, what the HYT model does, it takes the QALY, it starts from the QALY model, but then it subtracts this loss, which is the difference of the quality adjusted life year from that expectation from the reference point from what I have said. what on average the patient population sets. And this Q star and the L star is constant. It is the maximum possible of life expectancy and best possible health possible. And it's the same for everybody in the population, in this case, in a population kind of setting. What turns out that once we follow this metric, it has several nice properties. First of all, it actually algebraically just decomposes the longevity part and the quality of part as an additive component instead of a multiplicative one, right? So from any treatment K, there is a healthiest from longevity, which is just survival, which is your life expectancy from that treatment. And then there is a healthy years from quality of life from the treatment, irrespective of the longevity, which just says what quality of life is you would experience if you take this treatment times a constant life expectancy, which is kind of a maximum life expectancy you would expect to live. So a classic example of this is that suppose for localized prostate cancer, suppose a surgery gives you the highest life expectancy of 20 years, and then chemotherapy gives you 10 years, and say immunotherapy gives you 15 years, right? The life expectancy L for chemotherapy and immunotherapy is 10 and 15 years. That's directly observed. But the quality of life from chemotherapy, you are evaluating as if that had you lived for the 20 years of life, what would have been your quality of life? Versus had you lived 20 years of life with immunotherapy, what would have been your quality of life, right? So you're focusing on the quality of life part without having to multiply with differential life expectancy along with it. So it kind of separates out those two components, a quality of life component and a life expectancy component. So it turns out, and then any increment in health, so if you're comparing chemotherapy and immunotherapy, then it separates out into a life expectancy gain component and the quality of life gain component, or the gain in healthy years from quality of life, because L star is constant, it's kept constant. So it's mostly driven by how the average quality of life is different between the two treatments. So it really kind of naturally sets out how often in focus groups patients have expressed, I think about life expectancy and I think about quality of life. It kind of separates those two out. Now, it turns out that if you apply HYT to these two populations, it exactly gives the right answer that you expect. In the first comparison between two populations, it does not give differential answer because the gains are the exact same for life expectancy and quality of life. And in the second example, where there is difference, it identifies the difference correctly. So it solves kind of both the quality of QALY problem and the EVL problem. There is other aspects, other interesting kind of properties of these kind of health years in total. First of all, obviously any common health, often when we think about resource allocation decision of pricing, needs to be multiplied with some common opportunity cost to convert them to dollars. But one can always add some weight to those opportunity costs to say that these gains, health years gain and health years from quality of life, is being realized in the population who have a very high disease burden. And so you can always increase equity weight to increase these opportunity costs. And we have done so for sickle cell, and I can show you. And there's a long distributional kind of cost effectiveness literature that shows how to calculate these equity weights. More importantly, one could also put different weights on longevity versus quality of life. Suppose there's a population of patients where longevity is more important than quality of life. One could, or a decision maker could put a differential weight on the longevity part compared to the quality of life part. The key here is that health years does not formulaically say what those weights are. We feel that those weights should be derived by a deliberative process with patient input and in a transparent fashion, so that we know exactly what was the process of arriving at those weights and the decisions. Finally, in the recent analysis, we applied the health years in total metric to value the sickle cell gene therapy. And I'm not going to go into too much details, but I'm going to show that in the right-hand side, this is a figure that we often use in the health economics and outcomes research literature. It's called the probability of acceptability. So on the x-axis, you have the prices of gene therapy. And on the y-axis, it says, because there is uncertainty around these estimates, it says how likely at this price would this technology be acceptable, acceptable with some opportunity cost threshold. So the solid lines, the light solid line and the like deep solid line are the QALY based estimates. It says if the price was $1.5 million, it was highly acceptable. The acceptability was over 95%. But if it's $2 million, it is not so much acceptable. But then if you use an equity-based threshold, so instead of 100K per QALY, use 150K per QALY, which we calculated to be the right increase in equity-based threshold for this population. Now, even a $2 million price would be highly acceptable, and a $2.5 million would not be as much acceptable. But then the dotted line are the same concept, but with health years in total. And as you can see, especially for technology that improves life expectancy, on average compared to QALYs, it shifts the acceptability curve right, which means at the same level of price or the coverage, you generally are more acceptable to take these treatments. So in this case, at even at $2.5 million with the equity informed threshold, you should have a very good high acceptability of accepting the gene therapy. Finally, I think it's a good idea to just have a lay of the land to see what's going on and compare the different metrics that are available. So I spoke about QALY, I spoke about EVL, and obviously health years in total. Obviously, you have heard about GRACE, which is again a more elaborate model that tries to incorporate many of the parameters around severity and risk perception in the model. You know, it's a fascinating model. I often feel for policy decision making, it's like taking a Lamborghini to do grocery shopping every day. And I wanted to compare the different attributes that one can think of when applying these metrics. So one of them is it guaranteed to meet the IRA restriction? We know that the QALY does not. We know the EVL and HYT does. The GRACE, it's not clear if it does, because the GRACE puts different weights on severity distribution. To what extent, in some cases, those weights may not lead up to producing the exact same valuation of the same increments. So there is no guarantee that it will do. In some cases, if for more extreme severity, GRACE does value them more than the low severity, but not for all levels of severity. One of the biggest challenges that we face is that can we continue to use the current quality of life weight? So there's a vast literature of quality of life, and we are continually improving it. There's some discussion about, and we can talk this more about going from general population to patient-specific population to measure quality of life. But the process of eliciting quality of life is pretty standard. And one of the things that GRACE shows there is that, you know, when we convert health to this quality of life of health, it should incorporate measures of risk seeking and risk averseness, which is correct. And there should be curvature in that model. But when we look at the empirical data on quality of life, we already see curvature, right? And we already see that the people are risk seeking at the lower end and risk averse lower end. So if you take that quality of life and add these GRACE parameters on top of it, there may be an option of some overcounting or double counting going on. So there is a little bit more work done. So how do we use, like if you want to do an economic evaluation GRACE, how do we do it with the current quality of life and add that? So that needs to be kind of thought of. Now, does it value all aspects of quality of life, life expectancy gains? And GRACE, quality of life, and HYT, you know, all does value all aspects of it. Or EVL, as I showed, does not. because it misses that part when the quality of life gains happens during the life expectancy gains. And then the other one, does it follow or does it allow for a deliberative process to inform severity correction? And this is where I think the grace falls short, because obviously there's a very formulaic approach to kind of say, okay, here are the severity correction, without a more general discussion or deliberative process of involving patients and say, how much of severity we should be thinking of. So that's something that needs to be. I mean, in my opinion, you can take the GRACE model, the GRACE concept, and apply any of these metric, and then have a deliberative process to actually apply those severity correction instead of having a formulaic approach to it. And then finally, which is often underrated, but it's extremely important, is how much difficulty would you have to communicate measures to decision makers and patients. And QALY, I think, is the easiest because it has been around for such a long time. When initially QALY came up, it was a very difficult concept to grasp, but it's been allowed for 30 years, 40 years, and so it has become more general mainstream. EVL is slightly more difficult because there are those nuances to it. GRACE, I feel, is quite complicated, and HYT, well, you guys will tell me if it's reasonable or not, and what would be most confusing to you to think about HYT. So in conclusion, I think Health Years in Total presents an alternative formulation of effectiveness metric and cost effectiveness analysis with many attractive properties, but more importantly, it kind of aligns the health measurement or the health representation in the same lines that we have always found in qualitative interviews with patients and caregivers, is that there is a thinking around the life expectancy gain, and there's a thinking around the quality of life gain, and then kind of breaks it down in those metrics. It does not violate the IRA principles, and it forces decision makers to be explicit about the distributional aspect of how they take these health gains, but value them differently across different populations, instead of hiding everything within a formula for health. And obviously, this is a new metric. It's been only around 3 or 4 years, and so more work subtly is needed to be done, as we did for QALYs for many years. So I will stop there, and I'm happy to take any questions.
Excellent. Well, thank you so much for this presentation. I think everybody, great. I'm getting a couple of questions in already. So I think everybody has been really interested, and I think the approaches you spoke to were very health literate and approachable, which we appreciate, because I'm also not a health economist, so that's definitely appreciated. So one of my questions, so I'll go first, was during this process, so did you work with any patient organizations or patients specifically? I know you had the case study on sickle cell anemia, so I'd love to hear kind of any tips you have for patient engagement in that realm, or how you kind of incorporated the societal perspective in that, because as you know, the patient orgs on the call, that's something that they're primarily interested in.
Yeah. So very good question. When this was being developed, when this was just came out, it was a theoretical model. But at the same time, we were doing the sickle cell, and in previous iterations, we had a lot of focus group participations from genomic medicine, like what people care about genetic therapy and what they care about. So we had a lot of qualitative input from those interviews, and then the sickle cell. What I would like to do going forward is, as we understand, one of the things that often kind of, when we develop these health metrics, is kind of seeing, do individual patients think the way that we are thinking in terms of these metrics? And so there's a lot of work. People have done discrete choice experiments or kind of other interviews to give them choices and see how they're making choice, and see if they align with how HIT or QALY would have made the choice. And so definitely the plan is to actually engage more patient engagement in those forums, and really kind of ask the actual experiencer to make those decisions for us. So yeah, absolutely.
Thank you. And we have, I just got a question in the Q&A.
Mhm.
So it's a little long, so I'll go slowly. Given that real world decisions about whether how to cover treatments and the added value of one treatment versus another are typically made in the context of a particular disease, like a new cancer treatment is not assessed versus treatments for asthma, is a common measure of health really needed? And given their reductionist nature, doesn't using such measures risk misleading decision makers? What about more patient-centric measures, or at least disease-specific measures?
Yeah,
I can
yeah,
add that into the chat too. That's a long question. I know there
yeah,
were
yeah.
that was a tough question.
Right. So let me just answer that question. And I got the gist of it. Is that like, is it necessary for a common measure? So let's take cancer itself. So cancer is not a homogeneous disease, right? There are so much heterogeneity across cancer. Prostate cancer is very different from breast cancer. It's very different from lung cancer. And they have many, many different disease-specific kind of attributes to those. If you do not develop a common metric of health, um, how would we know that we are pricing a technology for prostate cancer very differently than we are pricing breast cancer? Like, there is no sense of equity that we could ever assess if we just have very disease specific measures to make population level decisions. Um, for example, there's a lot of work, I mean, the sickle cell population is a classic example, right? The sickle cell population has kind of clamored for a long time that we are being neglected because, our health and our attribute, because it's mostly pain, it's not visible, we are not being measured properly and therefore not attributed. Now, you can develop a metric specifically for sickle cell disease, but you can still undervalue those metrics because you're not comparing to any other reference metric by the which you are paying cancer or cardiovascular disease. A common metric is useful because it keeps the same playing field for all diseases so that both the population decision maker and the patient groups can understand how much are we being valued or less valued compared to others so that we can have a discussion around it. And so I feel like there's an importance of making these common metrics. Now, I must say that any common metric cannot potentially pick up all the nuances of a disease. So that's absolutely understandable. And that's why the context matters. These metrics is not the all end all and overall for decision making. And that's why the deliberative process is important. That's why all the other constraints and the patient experiences becomes important, so that when the final decision, whether it's pricing or coverage or whatever it is being made, all those aspects becomes part of it.
Thank you. And you reminded me during our first webinar, we had a patient primer on just what was value assessment, patient-centered value assessment. And Dr. Joey Mattingly from the University of Utah had a slide that just said, life is complicated.
Yeah. Yeah, and so
So
is decision making. We think that decision making is hard because in general public policy is hard because you have to make these trade-offs, and trade-offs are hard.
Well, I have a couple more questions. One is a little more general. So as you know, some of our patient organizations and membership are often asked to submit data or information to value assessment bodies when they're doing a review of a drug. So this person asks, for patient organizations seeking to provide data for economic evaluation, what type of data do you recommend they submit for quality of life?
No, that's a very good question. And I think there is a new movement that's happening. One is, like, historically, when we measured quality of life, we kind of described the health state to a general population and elicited their preferences. And there are two reasons to do that. First of all, it's because these metrics were used for informing decisions in a broader insurance context, and there's a and everybody pays into insurance, and the patients actually, when they have a condition, they get the value, and so the original idea was that, well, we should be understanding everybody's preferences about how they feel about these health conditions so that they can pay in the pool into the insurance. What we have found over time is, especially for, not so the general population, even without experiencing it, can can have a good sense of if the condition is extremely severe. And if the condition is not severe at all, right? Like you have a flu for a couple of days, everybody kind of experienced it, and so they have understand. But in between, there is a lot of misunderstanding of what that health condition. And again, sickle cell is a classic example. When you think about pain and suffering, it's unless you've experienced it, it's very difficult to say what those are. So there is a movement that shows that, well, we should be eliciting these preference quality of life from the people who have experienced them, right? From the patients, right? Now, there is a counter argument to that, is because when people have experienced this for a long time, they tend to adapt to that condition. So a general population may actually give a lower quality of life for a condition than a patient kind of who is experiencing it because they have adapted to that condition. But I think the adaptation story, which is a theoretical story, empirically has not kind of played out quite often. So to cut matters short, I think taking health states and eliciting quality of life from actually people who experience it and comparing it to people who have not experienced, you are doing that anticipated kind of quality of life. I think it's a very powerful argument about how this quality of life measurement needs to shift towards more people who have experienced it. It creates challenges because, as you know, there are so many patient groups and so many, and so understanding, doing these calculations for all those things, it's often difficult. But even if you have some measure or some formula by which you can take the general quality of life and translate into, like, if patients were to answer these questions, what would the corrections you would make would be of great importance.
Thank you so much. There's one more question that I see, and it kind of continues along this same line, and I think it's a perfect segue, but what message can you provide to patient organizations who are seeking to engage with experts like yourself? I think part of so much of what you mentioned was collaboration. So,
Yeah,
looking at the data, looking at the patient populations, getting that qualitative research alongside the quantitative research. So,
yeah.
what kind of advice do you have for the patient orgs on the line?
Um, uh, well, one advice I would have is that, I think where possible and where resources are available, I think forming registries is very important. Because if I were, like, a classic example, again, with sickle cell disease, there was no registry data. So I wanted to go and actually measure this quality of life from patients, but there's no full registry where I could go and actually, kind of access a decent, like, the sample size becomes an issue. Sample. So we actually did some actually original data collection from patients at St. Jude's, but again, that was just one institution, right? And so when we do, or when we kind of try to approach and engage actually patients and caregivers, and I must agree that it's a difficult proposition because many patients are not at a stage that they would like to engage. I mean, obviously they have to deal with their own things, right? But having a registry really helps us to kind of reach out to a broader population base and then kind of have them engaged in research.
Well, thank you so much again, Dr. Basu, for joining us. We're right at time, and
Yeah,
we got some great questions in. So thank you everybody so much for being engaged.
yeah.
We hope that you'll join us October 2nd for this next webinar. I'll put the information in the chat for everybody. And again, excellent research, and we appreciate you sharing all of your insights with us.
Thanks for having me. Much appreciated.
Thank you. Have a great day.
Thanks. Bye.
Bye.